Okay, in this next and last section, we're going to talk about valve disorders as well as heart failure. So valve dysfunction can be separated into two really different types of issues, either valve stenosis or valve regurgitation. Yeah, so valvular stenosis means the valve leaflets are not opening up as they should. So when it's time for the valve to open and either blood is being ejected from the ventricle or blood is passively flowing into the ventricle, you can't get the amount of fluid you want, sort of like a funnel. That's what stenosis is. Regurgitation means that when it's time for the valve to close, it actually opens up, doesn't do it like it's supposed to. And that problem means that when it's time, say it's time for the aortic valve to close, if it doesn't close all the way, then there's going to be backflow into the opposite chamber. So we'll talk through a couple of valve disorders so we can see what that means. So that slide is showing you the difference between valve stenosis and valve regurgitation. So first, the person might have any of types of valve disorders may present similarly in some of their symptoms. Although if you're really good at physical assessment, you could actually try to differentiate heart sounds to be able to see this or to be able to sort of figure out what's going on. But you have to look at which valve is affected, if it's regurgitation or stenosis, and that will help you kind of predict what symptoms occur. So mitral valve stenosis means the problem is with this valve, and if it's a stenotic valve, that means when it's supposed to open, it is not opening all the way. So the valve's here, instead of going like this, and its flaps going down to allow for movement, it's like this. So you don't get the same amount of flow. So the mitral valve should be open during which phase of the cardiac cycle? Hopefully that's easy for you to answer. That should be diastole. That's when this valve is supposed to be open and the aortic valve is supposed to be closed in order to allow for passive filling of fluid into the ventricle. Then, if during this time when the mitral valve is supposed to be open, not enough of the fluid can get into the ventricle, then there's going to be an increase of fluid in the left atrium, and potentially as that fluid increases, it could backflow into the lungs. And so the symptoms of mitral valve stenosis have to do with an increase of pressure in the left atrium, which can contribute to atrial fibrillation, as well as an increase in pulmonary congestion. Because, again, we have to go back to our first class, if there's an increase in fluid in pulmonary veins, there's an increase in fluid in these veins, that means there's an increase in hydrostatic pressure, which favors filtration, causing fluid to leave the vessel and go into the lung parenchyma, which is why you hear in the tubes, which is why you hear the water, the crackles when you listen to the lungs. So that is mitral valve stenosis. It can be associated with rheumatic fever, and again, it can be associated with atrial fibrillation. So then there's a really nice picture of what a stenotic mitral valve can look like. If the problem is mitral valve regurgitation, the valve again is the atrioventricular valve between the left atria and the left ventricle, but the problem is when the valve is supposed to close, and the valve is supposed to be closed during systole. During systole, the mitral valve is closed and the aortic valve is open so that when the ventricle contracts, the blood volume goes into the system. So if this valve doesn't close all the way, then when the ventricle contracts, some of the blood will go back up into the left atrium, which will again potentially increase the size of the left atrium, and again lead to pulmonary congestion because of that. Again, predisposing the patient to atrial fibrillation. So this condition isn't really associated with rheumatic disease. It's more so associated with left ventricular enlargement and other conditions, but what is happening is the same in terms of backflow into the atrium and then increase in pulmonary congestion. So now if I was very good at physical exam, what I could do would be to try to listen for turbulent flow, which is what a murmur is, and see what part of the cardiac cycle is the turbulent flow. If I heard turbulent flow during diastole, then which valve is the problem? Or what valve condition is the problem? It would have to be the valve condition that occurs during diastole, which is mitral valve stenosis. If I heard turbulent blood flow during systole in the area of the mitral valve, then the issue would have to be regurgitation, because that's when that valve is supposed to be closed. So you can try with physical exam to try to find these issues, and that is something that we'll do in physical assessment. You'll see the next valve disorder that's listed as mitral valve prolapse, which is actually much different than regurgitation and stenosis, but it's still a valve problem in that area. What happens with prolapse is that mucin or gelatinous material is inside the valve, making it floppier, bouncier than it's supposed to be. And for some people, that means that when the mitral valve is supposed to close, there'll be it kind of flops a little bit, and they can feel that flop, sometimes like a palpitation or like a fluttering in their chest. And it's not that the heart rate is off itself, but that they can feel that change. Mitral valve prolapse, sometimes people sort of just get used to it and they don't really notice it over time. It's more of a problem if the prolapse becomes so severe, it's such a big ballooning effect into the atrium that it can lead to more chest pain and lightheadedness and such. And so sometimes that's something that people repair, but not always. So I'm not sure if you saw that battery running low message, but clearly this is not my 100th production. I'm new to this. So anyways, that was mitral valve prolapse. Now we're moving on to an aortic valve disorder that can be very common. That's aortic valve stenosis. That means that the aortic valve, when it's supposed to be open, does not open all the way. The aortic valve is supposed to be open during systole, because that's the time where the ventricle contracts and allows fluid and blood to go into the aorta. So if this aortic valve isn't open all the way during ventricular contraction, there will be a lot of pressure here in order to try to get the blood out. It increases resistance to flow and will lead to increased wall thickness of the left ventricle. This can be quite a serious disease. The ventricular hypertrophy can exceed coronary arteries reserve, and this condition can lead to heart failure, which we'll talk about when we talk about heart failure itself. And then there's a picture of that stenotic aortic valve. What happens with aortic regurgitation is that we allow backflow of blood after systole is over. So the valve regurgitation means that the problem occurs when the valve is supposed to be closed. The aortic valve is supposed to be closed during diastole. So aortic valve regurgitation occurs during diastole. That's when you could hear it if you were listening. In that time period when this is supposed to be closed is when there's supposed to be passive filling of the left ventricle. If the aortic valve doesn't close all the way, then some of the blood that was supposed to go forward will end up going backwards, and you'll end up with increased pressure, increased fluid inside the left ventricle, which will also eventually lead to heart failure and a backflow of blood into the lungs. And now we're getting to the last portion of the lecture, which is about heart failure, which sometimes people have a little bit of trouble with because you do have to change how you think about heart failure a little bit than how you thought about it as a nurse. Every time we talked about heart failure as a nurse, we're always talking about left-sided failure and congestion into the system or the lungs. And now we have to push our thinking a little bit because heart failure is a continuum of symptoms. Heart failure for adults is generally caused by hypertension. For children, it could be related to those types of things, but more likely related to an infectious process or a congenital abnormality. But heart failure itself is actually divided into diastolic heart failure versus systolic heart failure. And either of these types of heart failure could occur on the left side or the right side. So if you really put that together, you could have left-sided you could have left-sided systolic or diastolic heart failure. You could have right-sided systolic or diastolic heart failure, or you could have both-sided of some combination. So there's many types, many ways to describe why the person has heart failure, which does change the treatment. So it is kind of important. So the two main things that we're going to talk about is diastolic heart failure, which means the problem of the pump, the failure of the heart pump occurs during diastole, which is when the ventricles are supposed to fill. And that type of heart failure is called a heart failure with preserved, that's the P, ejection fraction. Because the problem isn't during systole, it's during diastole. The other type of heart failure is systolic heart failure, which occurs during the systolic phase. So there's a failure of the pump during systole, and that means it's heart failure with reduced ejection fraction with an R. And we're going to talk about those and their relationship to hypertension, which is the most common reason why adults develop diastolic heart failure into systolic heart failure. Although, as we saw when we were talking about valve disease, aortic valve disease can lead to both systolic and diastolic failure. The same is true on the other side of the heart. Pulmonic valve disease could lead to diastolic or systolic failure on the right side of the heart, and pulmonary hypertension could also lead to diastolic and systolic failure on the right side of the heart. So it's a complicated condition, and so sometimes people get a little frustrated with this section. So since it's on video, you can watch it a couple times. Hopefully that'll help you. Okay, so let's say the person has continuous hypertension. Okay, so let me describe. Obviously, this is not the heart all the way. My husband has already told me that my heart looks like a floor plan to a building or a room. This is just the left side of the heart, the left atrium, left ventricle, out into the aorta. Let's say that this person has hypertension. Their blood pressure is high. We know that that's increased stress to the muscle of the left ventricle. And the way the body would respond to that increased stress is hypertrophy. That's from the first class, which means that the muscle will get thicker because this muscle has to work harder in order to pump blood out into the system. But it's still able to do that. And that's really the first part of the continuum of heart disease that's caused by hypertension, which is what is called left ventricular hypertrophy. Over time, the left ventricle becomes big that at rest we might not notice any symptoms, but when we increase activity, we might start to notice symptoms. And what this means, what we're going to start to develop, is what's called heart failure with preserved ejection fraction, or diastolic failure. That's the next section. So what happens is if I'm trying to increase the volume of blood that goes into this ventricle, I'm not going to be able to do it because I've decreased the chamber size, and that's the problem. Decreased chamber size. The muscle is taking up space. So in normal conditions, I might not notice anything, and my ejection fraction on echocardiogram would be 60, 70%, which is normal. But say I wanted to exercise. I started to go for a walk or a run, which means my skeletal muscles will milk the veins and increase return to the heart. If I increase preload, that means I'm trying to increase the volume, increase preload. But this ventricle is unable to accept that larger volume that I need in order to do my activity, which means the blood will start to flow backwards. So when I am trying to increase my activity, I'm going to feel short of breath and not well. Like I'm not going to feel like I'm able to do it. When I stop, I'll probably feel okay. And so I would present to the clinic with symptoms with exercise or with increased activity that weren't quite chest pain, but really like this really bad shortness of breath or just discomfort of some kind. And then the problem could be diastolic heart failure, meaning that I don't have the chamber capacity for the volume of blood that's needed to increase activity. So if I was at that doctor's office again, the nurse practitioner's office, and I said I have these issues during exercise, and I listened to the person's lungs at that time, they're not exercising, they're not feeling the symptoms, I'm not going to hear anything different on my lung exam because there isn't a constant backflow and venous congestion leading to increased hydrostatic pressure, leading to increased filtration. I just know that when they are exercising, they have a problem. So it's going to be harder for me to determine just on my regular physical exam. But this is going to be a problem over time. Unless I correct the hypertension, this is going to continue. So over time, I am going to start to, this chamber is going to become so big that my coronary arteries aren't going to be able to support this muscle size. So there will be, what will happen is called ventricular remodeling. This is because of the influence of the renin-angiotensin system, particularly angiotensin 2, as well as the amount of muscle mass and the decreased ability of the coronary arteries to feed it completely correctly. It's going to change the quality of this muscle, where it's not going to necessarily be as good. Maybe it starts to get kind of stretched out. That stretched out heart muscle is going to be, oh, it looks like a St. Nick's sock. That's not what I meant. But this stretched out muscle is going to lead us to the next step, which is heart failure with reduced ejection fraction, or what is systolic failure. So now fluid is going down into the ventricle like it's supposed to during diastole, but a muscle that is widened or what's called cardiomyopathy or kind of bigger will not contract in an efficient manner, and so the ejection fraction will reduce. So this goes back, and we didn't talk about it too intensely earlier, to what is called Frank-Starling's law. Frank and Starling were two scientists that realized that part of the reason that we had cardiac reserve. So we talked about venous reserve. You know, the vessels are compliant. There's storage for increased preload for activity. Well, the heart itself is actually made for reserve too, to accommodate that increased venous return and to increase efficiency of contraction in times of exercise. So the cardiac muscle fibers, the actin-myosin filaments, are not lined up as efficiently as they could be at rest. They're a little crossed. So when we increase venous return because we've the skeletal muscles have milked the veins to increase blood into the heart, we stretch the ventricle a little bit and actually line up the actin and myosin fibers better so that the contraction is actually more efficient and stronger in the time that we really need that blood. And that is what the heart, so the heart has a built-in reserve for increased blood volume. But like everything, it's only to a point. So if the blood volume in the heart gets to be too large, then the actin and myosin filaments get stretched apart, and then the contraction is very inefficient, and ejection volume goes down. And so when the heart gets too enlarged because of remodeling or changes in the ventricular muscle that leads to cardiomyopathy of some kind, then when it's time to eject, the ejection isn't as strong and fluid is left behind. So the ejection fraction is smaller and the volume of fluid left in the ventricle is larger, which contributes to an increase in stretch of the ventricle, so it becomes worse and worse. And that is when we're going to see the pulmonary congestion, because the fluid will backflow into the lungs. So this person will have symptoms all the time, and they're going to feel it at times when they're trying to sleep. They're the person that's going to want to be on multiple pillows. They are the ones that are going to have cough with sputum production. When you listen, you're going to hear crackles because of the increased filtration of the pulmonary veins. That's reduced ejection fraction. This could eventually lead to right-sided heart failure. So everything we talked about so far related to hypertension was occurring on the left side of the heart. So our symptoms were felt in the lungs. Eventually, over time, this reduced ejection fraction or systolic heart failure on the left, as it increases pulmonary congestion, is going to increase external pressure on the pulmonary artery, much like hypertension did on the aortic side. This is external compression on the pulmonary artery. That's an increase in afterload on the pulmonary artery, which will begin to cause hypertrophy and then lead to a failure on the right side, which would then show backflow fluid into the system. So people can have heart failure on both sides or one side only. Hypertension, obviously, we said, is not the only reason why someone could develop heart failure. Someone could have a massive MI and have a decrease in the functioning of this ventricle, leading to systolic failure right away. They never had to go through those other steps. Perhaps they had a viral cardiomyopathy that changed the muscle itself and led to a systolic failure. Perhaps the left side was completely fine, and the person has genetic pulmonary hypertension, and so their issue is a right-sided failure over time. Or maybe they have a pulmonary condition like emphysema that leads to right-sided failure like cor pulmonale. Or maybe they developed a diastolic failure on the left side because they have severe aortic stenosis. So there's multiple conditions that can cause it. When you're thinking about it, think about one, when do the symptoms occur? Do they occur with activity only? Because then it's probably a diastolic issue. Are they all the time? Then it's a systolic issue. Is the backup in the lungs? Then it's a left-sided issue. Is the backup in the system? Then it's a right-sided issue. Is it both? Then it's both. So that might help you a little bit. So let me know if you have questions, and hopefully this videotaping works out. We shall see. Thanks.